All right. Well, good evening, everyone. I don't know if you can all hear me. I'm Russell Reed from plastic surgery at University of Chicago. And, welcome to Is Plastic Surgery the Career for You? A panel discussion to get to know the specialty. And, again, this is a great hour. We're very excited to have you on board, where we hear from different experts from the varying organizations in plastic surgery. And we hope that this hour brings you enlightenment of our great specialty. Again, this is a joint effort sponsored by the American Society of Plastic Surgeons, the American Council of Educators in Plastic Surgery, the American Association of Plastic Surgeons, and the Aesthetic Society. And without further ado, what I'd like to do in this first couple of minutes is just introduce our panelists. And I'm just going to go around the Zoom screen here, and start off with maybe Dr. Ueno. You want to introduce yourself?
The classic Zoom, don't forget to unmute yourself, right? Good evening. Thank you so much. I think it's a great opportunity, and thank you for organizing this and inviting me. My name is Cris Bueno. I am a plastic surgeon, associate program director at the Ohio State University. I've been at OSU for the past 2 years. Previous to that, I was at Kaiser Permanente and WVU, where Dr. Brook is. I trained at IU, Indiana University, and previously I had training in Brazil. So I have 2 board certifications, let's put it this way, one in Brazil and then another one in the US. Happy to be here.
Wonderful. Thank you, Dr. Ueno. I'm going to pass the mic over to Dr. Liu. Dr. Liu.
Hi, everyone. Thank you for having me. Glad to be here. And my name is Liu Xiangxia. So right now I'm at University of Tennessee Health Science Center at Memphis. And right now I'm the associate professor of the program. And my journal is very unique. I think it's based similar like Christian. So before 2021 is all back in China. So I graduated in 2001 and practicing as a plastic surgeon in one of the top hospitals in China, and for there about over 20 years, and was the associate professor and associate chief and the program director there. And family reason moved to United States in 2021 and start this practicing there. And the main focus in the I'm much interested in the reconstruction microsurgery, and then we can talk about it in the future. Thank you.
Wonderful. Thank you so much. I'll pass the mic to Dr. Brook.
Hi, good evening. Thanks for having me, and thanks for all being here. My name is Sebastian Brook. I am a plastic surgeon here at West Virginia University. Been here for about 3 years, after about 3.5 years in Texas. And I did all my training in the United States, but I'm originally from South Africa. And I do both general reconstructive plastic surgery with a focus in pediatric cleft and craniofacial, as well as reconstructive microsurgery, again, which is what we're going to talk a little bit about during the slides today.
Wonderful. Then I also see Dr. Marco Ellis. Dr. Ellis, would you like to introduce yourself?
Thanks, Russell. It's a pleasure to meet everyone here electronically via Zoom. My name is Marco Ellis, plastic surgeon at Northwestern University. I've been in practice for about 10 years. My background was primarily in craniofacial surgery and reconstructive microsurgery, but that's now since evolved a bit, as many careers do. And I'd say the majority of what I do is probably a mixture of both facial feminization surgery as well as breast reconstruction. But looking forward to chatting with everyone. I'm here as a representative of the Aesthetic Society.
Wonderful. Thank you so much, Marco. So again, we have a great set of panelists to talk with you. I think first off, what we're going to do is just kind of set a good foundation and, go through a slide deck. We have a slide presentation, which really kind of opens us up to the breadth and depth of our specialty. So what I'm going to do is turn it over to our panelists. I'm going to share my screen. And, again, feel free. This is going to be somewhat interactive. Again, we'll show our slides, but also want you to, for those of you who have questions, feel free to put the questions in the chat function or raise your hand. I think chat will probably be most effective, and then we can get to your questions. So let me see if I can share my screen now, and we can get moving with these slides. Can everyone see that? Okay, so we're going to go ahead and get started here. So again, welcome to the wonderful world of plastic surgery. We will go ahead and, talk about this great specialty. Again, plastic surgery comes from the Greek word plastikos, to shape or mold something. That's the dictionary view of what plastic surgery derives from. And again, it is working from head to toe, bringing back quality of life to our patients that we take care of. Again, not only bringing form to something, but bringing function. Plastic surgery covers the gamut, whether that is aesthetic, reconstructive. And you can see under the aesthetic, I'll probably have Dr. Ellis from the Aesthetic Society give a little brief blurb on that aspect of our field. And then reconstructive, you can see how varied we are, whether it's burns, congenital pediatric, hand, maxillofacial trauma, tumor, or microsurgery. Marco, you want to take the next few slides?
Sure, thanks. Yeah, happy to give some perspectives on aesthetic surgery. I would say we as a subspecialty get a disproportionate amount of press, but what we feel like we're a strong contributor overall to the practice of plastic surgery. And some of the elements that we think about are, yes, trying to improve appearance. I mean, that is an obvious goal, but you're going to learn shortly that is an important element of all aspects of in subspecialties of plastic surgery. I would say what we're really trying to do is to approximate or get closer to an ideal, whether that's based on sort of quality or sort of numerical scores. And as we look at some of these particular slides, you'll see examples. This is just a rhinoplasty of how we're able to reshape a nose and do it in a way that it not only can improve very obvious sort of proportions, but the sort of subtle aspects that patients really feel more confident and are more eager to participate in society after managing some of these areas that have been sore spots for them. Here with an example of a facelift, trying to actually reshape a person's face and remove some of the weight that you see along the lower border of the face and lower jaw, and actually redistributing that up towards the cheeks, where it's just a much more attractive and youthful appearance. This continues whether it's on the face, but even more so when we're talking about breast surgery. And these are sort of candid photos that can show how a woman's breast can change over time with weight gain, weight loss, pregnancy, and nursing, and how the breasts can be altered to obtain a new and a more attractive appearance. And that's with a combination of both use of implants as well as crafty incisions and sort of understanding of blood supply. And here's just a last example of how we think about aesthetic surgery and its role in body contouring as patients can gain and lose weight, which is especially common nowadays with certain medications. We are many times the go-to for patients to return back to their more ideal self and remove some of the extra skin and fat, as well as address musculature underneath. So it's quite an exciting subspecialty. Very happy to answer additional questions after you've had a review of some of the other aspects.
Thank you, Dr. Ellis.
I can
And go ahead, Dr. Ueno.
So similarly, I think to cosmetics, I think the goal of plastic surgery is really to restore the form. We basically take care of patients from congenital abnormalities to trauma, cancer, some disease, infections that led to change in the shape, form, function. So that is really the goal of reconstructive surgery. So the next slide is a example of areas that we act, and you're seeing there a burn. Burns are unfortunately common, and then in all ages, and it's something that we are very much involved because it will involve hand that is function, will involve sometimes face, extremities. So and we do a lot of like burn reconstruction also in mission trips. This is a rain plant, also part of reconstructive plastic surgery.
Dr. Brooke.
You know, within this reconstructive realm, we also have congenital or born with facial differences that happen. And this is a very wide range of presentations. Here, we've got two examples specifically of clefts, where this top baby has a bilateral cleft lip. And the upside down face that you see on the bottom is on the left side, a cleft of the palate, which is the roof of the mouth, that is open, and then that has been subsequently closed. And again, going back to this idea of reconstruction being a form and function sort of surgical endeavor, cleft lip and palate very much embodies that, because from an aesthetic perspective and patients' abilities to engage in the world, being able to fix a cleft lip has obvious tremendous importance. But from a functional perspective, the palate involves our ability to both speak intelligibly or swallow or create a suck and feed from a breast or a bottle. And so there are functional challenges that come along with these. You can go to the next slide. Additionally, in craniofacial surgery, just like the rest of plastic surgery, we're not limited to any particular body type, part of the body, or tissue type. So in craniofacial surgery, we can reshape the skull if the bones of the skull have been fused together too soon and don't have the appropriate space for the brain to grow. And here's an example of us reshaping the forehead on a baby whose two front plates of their skull have fused too early. And on the left side, you can see a child where they look a little flat on the right side of their face, and one of the sutures, which are the gaps between these bones, have fused a bit early. And what we can achieve in that child when they're a little bit older, giving them a more normal front-faced forehead. Go to the next slide, please. And this, again, is a wide range of problems where you can take very abnormal-looking skulls like this one in the top and go through a series of surgeries and techniques to try and get closer to a more normal skull that's got an appropriate amount of space for the brain to fully develop and maximize that child's potential. So once again, really much a function and form component of plastic surgery.
And plastic surgery also involves, as Dr. Brock is alluding, we have pediatric and adults, and this is an example of basically a thumb reconstruction in a pediatric population, and you can see the deformity and then the inability of the thumb to have function, and thumb is extremely important for us in our day-to-day. So, and then you see later how this child was able to adapt and have a functional thumb so they can have a normal life. Similarly, recreating thumbs. So sometimes patients either lose by trauma or some congenital abnormality. And in this example, the toe is used to reconstruct the thumb and the hand. Microsurgery, I think Dr. Liu is going to talk more in depth, but that means putting together small vessels and small nerves that you can allow perfusion to the tissue. In this case, it's a hand replantation, so it's a trauma, and where you have to reconstruct the bone parts, the tendon parts, the vascular aspect, as well as the nerve aspect. Unfortunately, trauma to the lower extremity is something that it's very common for us to see. I think more and more we are working together with orthopedic surgeons. As a reconstructive plastic surgeon, we work a lot with other specialties, and we coordinate care together, and it's a partnership. So basically, in this case, you see a foot and a leg, and you see a trauma to the tibia and a broken bone that required fixation. However, there's also a loss of soft tissue. Therefore, in order to, you can fix the bone. However, we cannot walk around with an exposed plate as a hardware. Therefore, this needs coordination of care with plastic surgery for coverage of the bone as well as coverage of the plate. In some instances, we're even coordinating to improve nerve function and do some nerve repairs as well with the orthopedic surgeons. Similarly, we're kind of in all parts of the body. I think in general, you see plastic surgeons taking face call with the ENT, the ear, nose, and throat, as well as the oromaxillofacial surgeons. And we manage from trauma as well as congenital deformity. So in this case, you see a trauma to the face with, you see how the kind of left side of the face feels that was basically smushed, right? Everything out of place. You see soft tissue problems. There's concerns for eye function as well as breathing, and then the bone structure. So we slowly go piece by piece and put the pieces of the bone together, then assure that we can provide function to this patient as well as a pleasant cosmetic result. Similarly, we work in conjunction. Sometimes we do, some plastic surgeons will do their their tumor resections. Sometimes we work together with the surgical oncologist, work together with the dermatologist, the ENT doctors. In this case, you see this huge tumor of the lower lip with loss of tissue, and then in here, we're able to rearrange the tissue around to do the reconstruction of the lower lip. On the other side, it's a skin cancer to the nose that required a reconstruction of the basically ala and tip of the nose. Sometimes we have other structures that are missing as well. Sometimes it's more than the skin, sometimes is cartilage, sometimes the mucosa, the inner layer of the nose. So all those things, when we're performing the reconstruction, we need to think about how we're going to put all these pieces together.
One of the exciting things about plastic surgery is that we also get to use technology as part, and I think that Dr. Liu is going to talk a little bit about this a little bit later as well. But here, as part of these surgical techniques, we can perform surgeries on the computer ahead of time and design cutting guides that allow us to take a piece of the one of the bones of the leg that's initially a straight piece and contour it to recreate a mandible. And in that picture in the top left, you can see that that is a designed plate to match the patient's original mandible contour with the fibula bone, which is from the leg, and place dental implants into that so they can get full dentition, and then using these microsurgical techniques of sewing blood vessels together to achieve a functional and aesthetic reconstruction for an otherwise complicated defect is a wonderful thing that we're able to achieve. And this is an example of a whole bunch of the microsurgical flaps that we sometimes do. From the top left of your picture, which is a tube, that's a piece of tissue from the leg to recreate somebody's pharynx. The middle picture on the top is the large piece of muscle from somebody's back that can be used to cover all sorts of large defects, versus a very small, thin piece of tissue from the front of somebody's forearm that can be used to close an important defect that requires only that small, thin piece of tissue to that bone and skin that you see on the bottom left with the mandible. And sometimes we can split these pieces of skin into multiple different pieces so that they can cover maybe more than one defect in one particular place. And this sort of is the advantage of free tissue transfer, where we can really use our wildest imagination to figure out what piece of tissue we need, what shape, kind, pliability, type of tissue. And as long as we understand the blood supply to tissue, we can transplant it anywhere on the body that it might need to be placed for reconstruction.
Dr. Liu, would you like to cover these slides?
Sure, absolutely. So you can see on the slides the breast cancer, and so what's our job is building the structure. For the tumor surgeon, they resect those tumors. You can imagine those breast tissue gone. And what we need to do is use some soft tissue from the body, other part of the body. Most frequently used with abdominal tissue. And the flap is called DIEP, is a deep epigastric inferior perforator flap that supplied those tissue on the bellies. So then we hooked in internal mammary vessels to get connected with the blood supply and reshape the volume and the shape of the breast. And also you can see we sometimes we can have the rebuild of the nipples and nipple areola, like a tattoo or some local flap, do that. And this is the donor side. You can see, we always say, buy one, get one free, which means like you get your breast reconstructed and then we get your belly to take care of. You get tummy tuck at the same time. So this is kind of, we're saying like just buy one, get one free, and the belly can close by primarily. Okay, and this is the secondary breast reconstruction, which means the patient already having the breast resections, mastectomy elsewhere, and she survived, and she's come to you, hey doc, I want to get my breast back. So what we do, you can see, basically we get some flap from other part of the body, same thing like abdominal, we could get from the thigh, we could get from the back of the belly. and we put on that, have a reconstruction the volume, and then we shape the breast, and you can see the tattoo on around the nipple area, make it the kind of perfect breast for the patients. And also this is more about cosmetically, but interesting here in the system, United system, they will the insurance will cover for the breast reductions, because as we all know, with the very large of breast tissues, it's a lot of symptomatically. You get the back pain, and that will not able to get through with the physical therapy. A lot of things you have to do, reduce the volume, reduce the weight of the breast. So what we do is, you can see on the right, we reduce the volume and also reshape the breast. It's the same thing at buy one get one free. You can get the breast lift in the same times. Okay, so this we are talking about plastic surgery innovations. Recently, it's a very hot topic, and the plastic surgery is about lymphedema. So we know lymphedema is a disease, either primary or secondary. What happened is lymphatic, the drainage return to the body get blocked. May come from, you got the tumor, you got the radiations, you got big resections in pelvic, all the lymphatic vessels being destroyed. So the distal part of the fluid can never go back into the system. They try to find a way. Sometimes they leak into the soft tissues, and they try to go back. Sometimes they get, balance between the output and input, so it doesn't bother you. But sometimes we can see, for example, on the bottom of the left, you can see a lady having a breast cancer, having the lymphatic, lymph node transactions and dissection on the axillary. That will disturb the lymphatic circulation back to from the hand, and you've got the swollen hand. It's quite embarrassing for those type of patient, and also it's very painful. You're having swollen every time, every second. So what do we do? You can see on the top of the right, we may zoom in a little bit. It's very tiny vessels. Just make a guess. How large are that vessels? Usually we say millimeter. Right now you can see it's just 0.3 millimeter. So we're using 12-volt sutures, big microscope, big magnifications. Then we can find lymphatic tract, and we do some anastomosis into the vein. So we call it LVA, which means like lymphatic venous anastomosis. Then we can change the lymphatic return into the surrounding vein, so that let the lymphatic fluid find a way back into systems. Then will significantly reduce the swollen of the distal part of the body. And that's called, and we can look at the bottom on the right. Sometimes you got a lot of significant extra tissues, which not only the LVA, but you have to do something we call to reduce the volume. We call liposuctions, and it's basically you use a small tube and you suck out all the fat tissues, fibro tissues, hopefully, and reduce the volume. And also you can do excision by excise those tissues to reshape the leg. Okay, on the top of on the left, the picture I want to introduce Dr. Zhou Zegan. He's a specialist in the lymphedema. So I have a visiting professor there for about a week. We have a wonderful week and take care of a lot of lymphatic, lymphedema patients. So I will always encourage you, if you want to go to internationally, there's a lot of opportunities, and to a short visit to a couple months visit or kind of the optional 1 year off, you're more than welcome to ask. I think we got a lot of resources here. Okay, let's go for the next. Okay, this is something very fancy. You may all heard about on the news, but actually I would say this is a quite significant development in the reconstruction part of a plastic surgery. Okay, let's look at the top on the left. The lady have a dog bite. This is actually the first facial allotransplantation case done back in 2005 in France. So the doctor transfer somebody else the face part of it, I would maybe say the middle of and the lower, and hook the vessel, hook the nerve, and so you can see that's a wonderful, wonderful result. And you look at the left on the bottom one, this is the case from Dr. Parkmark. He was at Brigham Women's Hospital in Boston. Right now he's at Yale University. And look at those pictures. The gentleman unfortunately had those devastating injury. And that picture showing that exactly what we already try our best to reconstruction as a traditional way, like you may heard about the skin graft, flap, a bone transfer or free tissue transfer. That's kind of the best we can have. But look at on the left one, the gentleman, it's pretty normally, he had those devastating injury. So that's the amazing result of facial allotransplantations. And you can look at serious case by Dr. Rodriguez at NYU. This is, we can see here, just 1 second. And basically on the top one, it's those injury, already been reconstructed by our traditional plastic techniques, but that kind of part is far away from what we thought it would be a good acceptable kind of the result from our perspective. So but we have to bear in our mind initially there's a lot of something I would say they are not looking good into these techniques, because think about it, for those type of patients, if you don't do the surgery, you will not die from the injury, you survive the injury. But when we do the facial allotransplantations, we have to put patient into immunosuppressions, which means you have to be lifelong to be immunosuppressed. This open the door for infections, open the door to some tumors, which can easily kill the patients. So in the early stage of facial allotransplantation, there's a very big controversial about ethic topically. But I think with the more and more case and with the more and more convincing results, either in short term or in the middle term, like 10 years from almost 15 years from now, people are more convincing for those significantly devastating trauma patient in the lower phase, in the middle phase, especially with the bone destructions and functionally with the well-selected patients, it could be options for those patients. But still, it's a very ongoing research, and we have to look at it. And I always encouraging you all, if you are interested in, you can get into this field. Hopefully, in the next kind of couple, possible 10 years, 20 years, this will be well accepted as organ transplantation. For example, you got kidney transplantation, liver transplantation. That's something we open the door, actually provide options for the patient for better result and a better, quality of life. And
Okay,
this is
thank
slide
you.
showing. Okay, thank you. Appreciate you.
Yeah, no, so thank you, Dr. Liu. Yeah, we can talk about innovation. Did you want to continue? I mean, again, one of the things in plastic surgery is that we are innovators. We're always pushing the envelope for quality of care for our patients, answering the most complex problems. And, that opens up, like Dr. Liu said, a whole avenue for research, innovation, and entrepreneurship. Dr. Liu, did you want to just talk about this briefly? Sorry, I think you're muted.
Okay, sorry. Yes, I think there's what I want to say is we got a lot of opportunities and fundings, and the society ASPS and aesthetic surgery. We can get connected after the follow-up email, then we can have those link, and then we have kind of open the resource to you. But always, I like said, encouraging you to look at it, and we can have those connected. I hand it to you, Dr. Reed.
Sorry, yeah, there's some malfunction in the slide deck. But, again, I wanted to kind of dovetail from this great presentation. Thanks to the panelists, about plastic surgery. Again, we should invite our panelists to give a little bit of time to talk about their journeys. But I also encourage our attendees to put your questions in the chat so that we can answer them. I hope that was just a presentation, just whetted your appetite about plastic surgery, who we are and what we do. Again, exciting things in the field. A plastic surgeon covers the gamut from head to toe, aesthetic and reconstructive, and we are innovators. So I'm going to just open up the questions really to the panelists, and just talk about, for the students, what tips would you have for students who are excited about plastic surgery and may not have a connection to a plastic surgeon at their home institution? How do you think they should go about delving more into the field and making themselves a strong applicant? Maybe Dr. Ellis, you want to start with that?
Yeah, sure. Thank you. It's a challenging question, and the reason why it's a little challenging for the students who may be on the call is it's a much more simple task when you have a dedicated plastic surgery training program nearby or at your host university, because getting activated and involved is as simple as just contacting that group and declaring your interest and getting involved in research projects and rotations. It can be quite straightforward. When you are not at a university or academic facility that doesn't have a program, then it requires us a little more work. Doesn't mean that it's impossible. Typically, the pathway that most folks will take is doing dedicated research years. So using that time, depending on your curriculum, between first and second year, second and third year, what have you, to then develop a longitudinal relationship with a well-known program. And for many people, that can be within their city. It's not like you live in middle of nowhere and now you have to make arrangements to go out to the Bay Area. No, you can most times find local host institutions that have a very strong commitment and are willing to take on students. I know here at Northwestern, we routinely work with students from, for example, Rosalind Franklin University, and a few others that are less well represented in our sort of neighboring states. So I would tell you to remain encouraged, and the fastest way to get connected is using a platform such as this today, or if you're involved in any additional society offerings like the Garnes Society. That's an excellent segue.
Wonderful. Thank you, Dr. Ellis. And I see these questions, the Q&A here that's coming up on the theme of the challenges that international medical graduates may face, or IMG students. What advice would you all have for those interested in plastic surgery, but are international medical graduates?
I can answer that.
Dr. Ueno? Yes, thank you.
I can answer that. I think that the hardest part when you're international medical graduate is that we don't know anything about your medical school. We don't know much about what you were exposed to, or your how your medical training was in comparison to the medical training in the US. So there's always that doubt, and a lot of the times when I look through the CVs, a lot of the international medical students, graduates actually, went and spent some time in the lab doing research, which is good because makes you visible and connected to other plastic surgeons in the US. I think the difficult part again is really knowing what you can do clinically versus what you can do in research. So I think the more you look for opportunities to participate not only in research, but also in clinical work, and see how you interact with patients, or how you collect data from the computer, from the EMR, how you use your composure in the operating room. I think those things are important. And it's hard to say, but I always encourage the students to do apply, not only for plastic surgery, but also through the general surgery route as well, because it is hard. Plastic surgery is a very, very competitive field, unfortunately.
Thank you, Dr. Ueno. Anyone else have any tips?
I think probably to dovetail of what both Dr. Ellis and Dr. Ueno said is that so much of it has to do with being open to an alternative pathway, maybe not the come out of school, graduate, go into a residency program, get through the residency program, do a fellowship, do training, but being really open to the experiences you will get by doing a research year or doing a preliminary surgical year if you're an international medical grad. That can certainly give you an opportunity to demonstrate your ability to function in a clinical setting within the United States healthcare setting and system, which is different to other systems. And that can help connect you with people that can then become mentors, because mentorship has so much to do with people's ability within plastic surgery who are within it to thrive and grow their career. I think if you look at all of the sort of giants of plastic surgery, all of them talk about the importance of mentorship. And so these experiences that Dr. Ueno and Dr. Ellis talk about connect you with those mentors who will then champion you and give you an opportunity either potentially at their own program or within the community, which is relatively small. And I think that those are excellent ways in which you can get into plastic surgery. And just that sort of answers some of what are the other questions, which are what are the alternatives? The alternative to an integrated residency is to complete full general surgery training and then join as an independent. There are always spots that are opening up in plastic surgery training programs around the country as life happens for people and they change careers and they leave programs. And if you are already in a general surgery training program or potentially a preliminary surgical resident, you then have the opportunity to apply for those positions, maybe even outside the match, and kind of keeping your ear to the ground for those opportunities are some of the alternatives as well. Went there.
Great, thank you. And a general question for our panelists from one of the participants. What was it about plastic surgery that drew you to the field during medical school? How did you know plastics was for you? Kind of talking about our different journeys. Who wants to lead off with that one?
I think I can. I'm sorry.
No, go ahead. Go ahead.
Yeah.
Mine is very short. I just met a really cool plastic surgeon as a teenager, and I was impressionable, and he was cool, and it kind of stuck with me. So.
Yeah, it's a for me personally. I mean, I remember just one afternoon. You know, I met a professor from plastic surgery. At that time, I still intern, not you know, get into the field. We talk about a lot of things, and then look at it. Oh, that's something I'm interested. So, but you get more and more into the field, and that's the correct answer. I think there's obviously there's a lot of options in, you know, surgical field or even the medicine field. Eventually is what you want. And from plastic surgery, I would say the very unique thing of plastic surgery actually would do two jobs. One is we reconstruction those deformities functionally, and you know, the second thing is we do cosmetically, which means like they are pretty normal, they want to be better. So that's something. It's not I don't think much of the other specialties have those incorporation into this too, and you can well incorporate this too into your practice. You know, you can focus more in reconstructively, or you can do more cosmetically as a private doctor. And this is all give you a lot of opportunity to that.
I got in love because of burns. I was a medical student, and I think I had this impression that everybody does, right? That plastic surgery is Dr. 90210, right? So it's all about cosmetics and this over sense of aesthetic that is not even, like, I would say probably not even normal. And then I went to a burn lecture, and at my hospital where I went to medical school, the burn unit was run by plastic surgeons, and I could see all these amazing things where we have really bad burns in Brazil. So patients were stuck like this, and all of a sudden they can look up and see the sky. And I think there's nothing more magical than that.
Thank you. Dr. Ellis, how about yourself?
You know, it wasn't really a eureka moment for me. So I always enjoy hearing you know, other surgeons describe their pathway. You know, I think it was always my interest in anatomy, and surgical anatomy, to be more specific. That one thing that I think we can all agree upon, all of the panelists here, is how much we just enjoy, you know, understanding just unique aspects of the human body, whether that's on the face, the abdomen, extremities. And that's not really something that is as emphasized in the other surgical specialties. They just have a more dedicated approach, which I respect. Nonetheless, I've always enjoyed the breadth of plastic surgery, and hopefully seeing the slide deck, you can truly agree that we do offer so much, and it all kind of boils down to a set of concepts that are slowly taught over several years in residency. But you know, for me, it was always just that broad sense of anatomy and the delicacy of you know, dissection and tissue planes.
Yeah, thank you. I mean, I know for myself, it was actually the avenue was through research. I didn't even know. I mean, I thought I was destined to be a pediatrician. I love taking care of kids. And when I got into a research lab, the research lab was into inflammation and wound healing. And then I met some plastic surgeons through that and found that plastic surgeons were very invested in research and translational research. And that's what got me excited. Then I did the sub internship, and the light bulbs went on. So yeah, it's exciting to hear different pathways, different ways to get to be a plastic surgeon, like our panelists have said. But I think really an important aspect is the aspect of mentorship, having somebody there who's going to expose you to the field, lead you, guide you. I think those are all important. And I hope that this, panel session and webinar opens it up for our attendees in terms of mentorship. I see another question here in the Q&A talking about, as a DO medical student, could you talk a bit more about my recommendations you have for DO students applying to plastic surgery residency? Necessity for taking step 1 in addition to COMLEX now that they're pass fail, importance for audition rotations, research, etc. Any thoughts on that?
Not any specific, not anything specific to DO other than the testing. I would say that the majority of the plastic surgery integrated training spots are used to looking at applications with the USMLEs rather than the COMLEX, so we're more familiar with what those numbers mean, and so. Although they have moved step 1 to being pass-fail, more and more programs are still looking at the step 2 score, which is the second version of that exam, and there is still probably benefit in taking that exam to sort of demonstrate how you as a student compare to the other applicants in the pool, because that's ultimately what we are doing, is looking to see how applicants compare. But there is more to one's application and the strength in their application than just testing scores. As we know, there are people who are great test takers that may not be clinically as strong, and there are people who may be not such great test takers who clinically could be incredible. And so that's when we're looking at a really well-rounded application which demonstrates that the students have got real passion because they are invested in the research. They are reaching out to programs and getting letters and meeting people and having mentors. And then also showing that they work really hard by how well they do in their rotations, their first couple of preclinical years, and then the sort of benchmark standardized tests, because ultimately we have to pass those exams as a plastic surgery trainee in order to become board certified and get through the residency program. And so we need to be able to demonstrate our capacity to get through those tests. So not any one particular thing, but probably still important to take the USMLE over the COMLEX because you are going to be compared against non-DO students, and that's the most even comparison that we can make, or objective one, maybe.
Yeah. No, thanks, Dr. Brook. I would agree.
Not if I don't know, if people think otherwise, I'd certainly open to that.
No, I would agree for sure. You want to get on the equator, I think, with the other applicants, and the majority of applicants have done the USMLE pathway. So I think it's, for a DO applicant, probably good to get yourself, into that side of evaluation for sure. Okay, I'm looking for any other questions here in our Q&A and chat. I
See
don't
why are
see.
plastic surgeons
Okay.
called the surgeon's surgeon?
Okay.
That's a great
good
great
one. There we
question.
go. I see that. Thanks, Dr. Brooke, for identifying that one. So what do you all think? Why are we the surgeon's surgeon?
I think it was Dr. Vetter gave a visiting professorship when I was a resident, and he drew a picture of the plastic surgeon circle in the middle and a wheel of spokes, and then listed all of the specialties with which we engage. And you guys got to see a little bit of that in a PowerPoint presentation, which is we work with orthopedic surgery for trauma, and we work with head and neck cancer surgeons and do reconstruction for them. And we work with dermatologists who are making sometimes not so small holes in the skin for skin cancer, or general surgeons who've got big hernias that need to be fixed, and OB-GYN surgeons that have large gynecologic oncology resections with big holes. And so we are the surgeon to help other surgeons fix the holes they can't close or fix.
Exactly. You have to have it's a very collaborative field. Partnerships are key, and that's what makes it exciting. Get to work with all other specialties, and there's a lot of cross-fertilization of ideas. Great. I see we're down to our last minute. Any parting words from our panelists? Also, I think I'm going to leave a little time for the administration just to talk about the recording of this video, and also keeping in contact with us. Any parting words? Anything our panelists would like to say to those budding plastic surgeons out there?
Plastic surgery I think it's an amazing field. Probably, I hope I know for some it's kind of like late in the evening and maybe tired, but we really, I think all of us, and I hope you got to feel that all of us love what we do. I think the advantage of plastic surgery is like, it's not just a gallbladder. You go there and do a lap chole, and there's just one way or two ways to take the gallbladder out, either with video or either opening. Plastic surgery, there are so many ways to fix one problem. It's not one way to do things. I think you can operate in every single part of the body. You can operate in every single age. And the good thing, I think, is like, as Dr. Ellis was kind of introducing himself, you can change and evolve with time, and your practice can evolve with time. So it's an amazing field, and hopefully the 20 people or so that stay in this call, hopefully you become plastic surgeons.
Exciting. Thank you so much, Dr. Bueno. And thanks to all our panelists. I think we'll leave it at that. Those are good parting words. Anything, Shayla, or administration you'd like to add?
Nothing on my end, but I will say for those that joined, we will send out the panelists and moderator contact information following this, so that you will be able to reach out to them if you have any additional questions that maybe weren't answered this evening.
Wonderful. Thank you so much. So again, thanks to our panelists. Our time is up, unfortunately. But, again, I hope this is the start of something for all of you who have attended, to get excited about our field, to reach out and, look for mentorship, look for opportunities to connect. So thank you all. Have a great evening. Thank you.
Thank you.